To get a successful percutaneous AV fistula, it's very important to have a very good pre-op ultrasound mapping to identify the perforator veins and the size of the renal ulnar artery and vein. Then to follow up a stepwise in the creation of percutaneous AV fistula, then closure, surveillance, and maintenance, and finally successful cannulation of percutaneous AV fistula. The two systems available in the market are the ellipsis from Medtronic and waveling from BART, and both required a specific anatomical inclusion and exclusion criteria for successful procedure and outcome. Both required a specific anatomical criteria, like both required an intact arterial system with a negative modified Allen test with a triphasic flow using ultrasound. It's very important to have an intact perforator veins, at least one suitable outflow vein, either cephalic or basilic vein with an inner diameter more than 2 mm using tourniquet, and finally patent central venous system. So let's start first with the wavelength system. It has required a specific anatomical criteria. Again, it required intact perforator vein, which is the most important part, radial or ulnar artery and vein diameter more than 2 mm at the anastomosis location and access site. The distance between the proximal radial or ulnar artery and vein at the anastomosis site should be less than 1 millimeter to prevent any extravasation or aneurysmal formation. And you can go either parallel or anti-parallel directions. There are special tips for percutaneous AV fistula using the wavelength. It's a full-fledged device in two catheter system. The arterial catheters can go through the brachial, ulnar, or radial artery. The venous catheter, which has the electrode, again go through brachial, radial, or ulnar vein. It required fluoroscopy and contrast. It has a magnet which holds the artery and vein together as radiofrequency electrode create the anastomosis. The most common area of anastomosis between the radial artery and vein or ulnar artery and vein. And usually the lateral radial and ulnar vein are the more common suitable for the anastomosis. The location of the anastomosis should be as close as possible to the perforator vein, and cold embolization of the brachial vein may require to help directing the blood from the deep system to the superficial venous system. This is one of our first case where the wire went through the brachial vein and the arterial wire through the radial artery. And this is the two catheters with magnetic holding together. This electrode coming from the venous catheters, and after firing, created a fistula between the radial artery and radial vein. And to augment the flow through the superficial venous system, we had to coil the brachial vein. If you look at the access and creation site, the most common creation site is a radial artery with a radial vein, about 62%, and ulnar artery with the ulnar veins, 37%. The most common arterial access site is the radial artery, 59%, brachial artery, 28%, and ulnar artery, 12%. The venous access, again, the most common is the radial vein, 53%, brachial vein, 40%, and only 6% through the ulnar vein. How good is this device? This is a very nice trial called NEAT trial, Novel Endovascular Access Trial. It is multi-center single-arm trial, use Everling, which later on became Wavelink. They have 60 patients they enrolled. The success in endovascular AV fistula creation was 98%. Physically suitable by ultrasound at 3 months was 87%. And successful use for dialysis was 64%. If you look at the primary patency at 1 year was 69% and secondary patency was 84%. So what they conclude that Everlink endovascular AV fistula demonstrate high 12 months cumulative patency with minimum complication. It may be a viable alternative option for achieving AV fistula. Then we have another study called an EAST study, which published a couple of months ago at Annals of Vascular Surgery. It's a multi-operator, single-center, single-arm prospective study. They have 32 patients, 6 months follow-up. They use Everling. Technical success was 100%, and cannulation was achieved in 78% by 3 months. If you look at 6 months, prime patency was 83%, and accumulative patency was 87%. So what they conclude that Everlink has an excellent procedure success with low rate of complication and high rate of function cannulation success and patency without the need for additional post-creation interventions. Another paper, this has more patient, 120 patients, is a prospective multi-center single-arm trials. This one, they use a wavelength, the new one. They look at 6 months prior patency was about 72% and secondary patency was about 82%. The time to maturation was 41 days, but if you look at the arterial or venous access complication was almost 0%. What about the second system, which is the ellipsis from Medtronic? It's a single superficial venous guide wire advanced through the perforator into the proximal radial artery. It required a duplex ultrasound guidance only, no need for fluoroscopy, no need for contrast. The device advanced over the wire, capturing both the arterial and venous wall, and when closed and activated, generate a secure anastomosis, and finally, sometimes required balloon dilatation of the anastomosis. So this is the needle going through the perforator to the proximal radial artery. The wire gets through to the radial artery. Then device go over the wire, capture both wall, and then activate it, and then you created the fistula, and then you do balloon angioplasty, and you end with a very nice AV fistula between the proximal radial artery and proximal perforator vein. The tips for successful AV fistula using the ellipsis: it's a single catheter and thermal energy. Perforator vein should be as straight as possible and more than 2 millimeters in diameters. Proximal radial artery again should be more than 2 millimeters at the anastomosis location only. The distance between the proximal radial artery and perforator vein should be less than 1.5 millimeters to avoid extravasation. Anastomosis is usually created exactly at the level of the perforator vein. For this reason, the location of the ellipsis anastomosis is usually slightly cranial than the wavelength created anastomosis, which make it possible that you can create ellipsis because AV fistula after failed wavelength AV fistula because there's more cranial anastomosis. How good is this system? This is a very nice single-center retrospective cohort study. They look at 234 patients using the ellipsis system. They have 99% technical success, no procedure-related adverse event, and they look at 1 year patency. Primary patency was 54%, primary assistant patency was 85%, and secondary patency was 96%. So where they conclude that ellipsis because AV fistula allow the rapid and safe creation of reliable autogenous axis and should be considered the next preferred axis option. And this is very nice also paper published in Journal of Vascular Interventional Radiology 2022. They compare wavelength with ellipsis and they found no significant difference in the primary patency. But when they look at cumulative patency, it was much higher for ellipsis, 82% versus 60% for wavelength. So what they conclude that both device has high technical success rate and adequate flow volume, but cumulative patency at 12 months was much higher for ellipsis versus wavelength group. This is again nice paper also published recently. They compare surgical versus percutaneous AV fistula using devices. It's a single center retrospective reviews. They have 107 patient ellipsis, 107 patient had a surgery. And they look at 1 year prior patency was much higher for the surgical group, 86% versus 61%. But if you look at 2 years patency was the same. Then look at the secondary patency at 1 year was the same, and the 2 years was again the same. So when they conclude that percutaneous AV fistula at 2 years follow-up has superior maturation rate, similar rate of percutaneous reintervention. However, the surgical AV fistula had required more frequent surgical revision. It has a lower risk of infection, a lower risk of steel and aneurysmal formation. So when they conclude that percutaneous AV fistula, although minimum invasive, has results comparable and in some respects superior to surgical AV fistula. So what our algorithm? Usually we like to start with the radiocephalic AV fistula or sniff box, and less frequently we do ulnar basilic AV fistula. The second option to do wavelength AV fistula, and after that ellipsis percutaneous AV fistula. If both failed, then we do brachiocephalic AV fistula, surgical, and finally brachiobasilic AV fistula. So conclusion, endovascular AV fistula has higher technical success with minimum complication and high 12 months cumulative patency. It reduces vessel trauma, leading to better fistula formation and potential decrease morbidity and improve patient acceptance. And it may be a valuable alternative option for achieving AV fistula for hemodialysis patient in need for vascular access. Thank you very much.